Hi everybody, and welcome to another short clip of palliative education. So what I thought I would do in this video is have a talk about fentanyl patches. Now, fentanyl patches have been around for a very long time. There's nothing new about them. But the reason why I think it's important to discuss them in a little bit more detail is the fact that actually sometimes people get tripped up by prescribing them, and there's one or two pitfalls that you need to be aware of when you're using fentanyl patches. Now, some of the problems that arise from prescribing fentanyl patches is that there are a couple of really important ground rules that you have to stick to when you're prescribing fentanyl patches. Now, the first one of those ground rules is that you can only prescribe them with patients who've already been established on strong opioids. Now, the reason for that is really to do with potency and how strong fentanyl patches actually are. And that's the thing that sometimes catches people out. The amount of opioid that you can administer with a fentanyl patch is actually quite significant. So if we take, for instance, a 25 microgram fentanyl patch, that's one of the lower patches that's available. In some countries, that's the level of fentanyl patch that you would actually initiate treatment with, and that's what the drug's licensed for. So that's one of the lowest patches, but it's actually, when you look at the oral morphine equivalent that's in the patch, it's actually about 90 milligrams of oral morphine equivalent that you're giving to the patient in a day. So clearly that's not the sort of opioid that you want to be giving to somebody who's never had strong opioids before. It's also sort of the level of opioid that you'd want to be pretty careful about giving to somebody who's perhaps quite frail. The sort of patients who react to medications and things. It's going to be a bad idea to give a fentanyl patch to somebody who really hasn't had that exposure to strong opioids in the past. So that's the first pitfall that sometimes people get caught out with, is actually these are really potent medications, and sometimes people just underestimate how potent they are. But if you stick with the ground rule that you're not going to give these to patients who've not had an opioid before, you should be okay. Now, the next issue that we have to deal with is that you shouldn't be using these patients for patients who've got unstable pain. You should only be using fentanyl patches for patients who've got stable pain. Again, it's for where a patient might have been established on an oral opioid and be quite well controlled on that, but for instance, they're having difficulty swallowing tablets, so you need to move to another route. That's where these patches are meant to be used. They're not to be used for patients who've got unstable pain. And probably the easiest way to explain why that is if we sort of hop over to the whiteboard and have a look at some of the pharmacokinetics that's involved with fentanyl patches. So let's have a little look at how fentanyl patches behave in practice, sort of focusing on the pharmacokinetics. And fentanyl patches are really quite interesting when you look at this. So let's draw a graph first of all. And what I'm going to do is I'm going to put time on the x-axis, and on the y-axis, if we for the sake of argument, let's call it efficacy. Really what I'm wanting to measure is really how the patch is behaving clinically. Are we up to sort of full operational capability? stability, really the sum of how the patch is being absorbed and getting adequate levels of drug into the blood. But just to keep it simplified, we're going to plot efficacy of the patch against time. Now when you do that, you get this rather interesting curve which looks a bit like this. So the important thing to note is that it actually takes a bit of time for the drug in the patient's system to get up to a level where it's going to provide the level of analgesia that you want. Now, why is there that time lag? Well, it's all to do with what happens when you put the fentanyl patch on the patient's skin. Now, the patch itself has a reservoir of drug that soaks through the patch and through the patient's skin. When you first put a patch on the patient, what happens is that the drug gets absorbed through the skin and forms really effectively a depot of medication within the subcutaneous tissue. And it's from that subcutaneous depot that you get systemic absorption. So that takes time. There's time for the drug to be absorbed through the skin. There's time for it to form this subcutaneous depot. And only when it's done that do you start to get systemic absorption of the drug. So you get this little curve. So initially, we've got no drug. When we apply the patch, there's then this period of time where it's forming the depot, and then as it forms the depot, you start to get leakage of drug into the systemic circulation. And then after a period of time, we start to get continuous leakage of the drug from that subcutaneous depot into the circulation. Now, what really catches people out here is just how long that period of time is before we get up to 100% efficacy. So if we were to take a point, say here, where we're not at 100%, but we're at about 80% of function of the patch, that period of time that we've got a delay is actually 3 days. So it actually takes the 72 hours that these patches work for. Even by the time you're changing the next patch, you still haven't got up to the full working potential that you would expect. And that's what makes these patches so problematic if you try and use them for unstable pain. Because you can't actually effectively assess whether your patch is doing the job that you want it to do until probably the best part of a week has passed. So these aren't the sorts of drugs that you can up-titrate on a daily or every other day basis. You should only really be making changes to fentanyl patches after quite a prolonged period of time. And that really renders them unsuitable for managing unstable pain. The other issue that you've got to be aware of is actually the reverse of this. That if you've got a problem with a fentanyl patch, you've increased the dose and then suddenly the patient's become opioid toxic, actually taking the patch off the skin isn't going to cure the problem very quickly, because you've still got that subcutaneous depot of drug still lingering around that's going to leach out opioid into the systemic circulation for some time. And again, if we were to draw a graph and sort of plot that against time, it actually takes about 3 days from removal of a fentanyl patch before you've actually cleared the opioid out of the circulation. So again, in an unstable situation, having a delivery method of the drug that means that if you run into problems, it's going to take a long time for you to be able to reverse that isn't a good idea. So again, fentanyl patches are a really neat way of delivering opioid for some patients, and they're very established, and if you use them correctly, they're incredibly safe. But you just have to stick to a couple of ground rules. And again, just to remind you of those, one, you only give it to a patient who's already been established on strong opioids, and you only use it in patients with stable pain. And that's where these drugs are meant to be used, that's how they're designed to be used, and if you stick to those ground rules, you'll be prescribing safely and effectively for your patients. I hope you've enjoyed that video, and I look forward to seeing you for another short clip of palliative education in the future.